Good morning, students. I'm going to talk today about ovarian tumor. What is ovarian tumor? Under normal conditions, the cell division will occur only when additional cells are required for normal body function. But if the control that regulates cell division is lost, there is a further and further accumulation of the cells without order. These cells will form a mass, and this mass will term as a tumor. We have three types of tumor in ovarian tumor. We have the benign type, we have the malignant type, and we have the borderline tumor. The benign tumor, you know what's the benign tumor. The tumor that is not cancer, it's rarely life-threatening, neither invade nor spread to the other tissue, and can be removed with a good prognosis. The new one is the borderline malignancy. What is borderline malignancy? Borderline malignancy is a groups of tumors that are intermediate between the benign and the malignant, both in the behavior and the histological feature. And also it's called the semi-malignant or low-grade malignancy. If it is a benign, this is the criteria of a benign. It can spread, it's the criteria of a malignancy. It can spread either locally or spread by lymphatic, and the prognosis is good. The malignant tumor is a cancer that spread beyond the ovary, and it causes damage and can grow back with a poor prognosis. I'm going to concentrate here on the ovarian tumor. It is a disease of old women. The classification of this disease depends on the origin of the ovary. As you know, embryologically, the ovary arises from three origins: the coelomic epithelium, from underlying mesenchyme, and from the germ cells that transfer via the peritoneum. And we have the other type, well, metastatic tumor. The tumors that arise from the coelomic epithelium known as epithelial tumor. The tumor that arises from the mesenchyme called sixth-cord or stromal tumor. The tumor that arises from the germ cell called germ cell tumors. I'm going to discuss what types of tumor or this is the cut section which shows the ovaries. The tumor that arise from the epithelium, coelomic epithelium is the epithelia. The tumor that arise from the mesenchyme, the sixth-cord tumor, and those arise from the graphian follicles known as a germ cells tumor. The epithelial tumor consists of 5 types: the serous, the mucinous, the endometrioid, the clear cell, and the Brunner type. A benign form of serous known as serous cyst adenoma. The malignant form known as serous cyst adenocarcinoma. Also the mucinous cyst adenoma, the benign, the mucinous cyst adenocarcinoma, the malignant, وهكذا. Now I'm going to talk about the sixth-cord tumor. The sixth-cord stromal tumor is the granulosa cell, thecoma fibroma, and arenablastoma, or known as Sertoli-Leydig cell. These cells or these tumors, they are sharing same feature. They arises in the old age female. Some of them, or almost all of them, they are hormone secreting. Like granulosa cell tumor secrete the estrogen, while the arenablastoma or androblastoma secrete the androgen, as we see later in the other parts of the slides. The third type of tumor, the germ cells tumor, we have 4 types of germ cells tumor: the dysgerminoma, the yolk sac tumor, the non-gestational choriocarcinoma, and teratoma. Also, they are sharing the same feature. They occur in younger or second and third decade. Almost all of them, they are hormone secreting. This germinoma secrete three types of hormones: the androgen, estrogen, and HCG. Yolk sac tumor secrete alpha-fetoprotein. The non-gestational choriocarcinoma secrete HCG, while teratoma is inert. Now I'm going to talk about the epidemiology. What are the factors that increase the risk of ovarian tumor, and what are the factors that reduce the risk of ovarian cancer? The age. Ovarian cancer is increased with advancing age. The smaller the family size, the more risk of ovarian cancer. There are special geographical distribution for ovarian cancer. It's increased in the Sweden and Caucasian, while it is less in Japanese and Africa. The previous history of pelvic irradiation increased the possibility of ovarian cancer, and the nulliparity or low parity is one of the factors that enhance the ovarian tumor. What are the factors that reduce the ovarian cancer? The early age of pregnancy. The earlier the patient gets pregnant, the less risk of ovarian cancer. Breastfeeding also is a protective factor. As we see from the early age of pregnancy and breastfeeding, there is a suppression of ovulation. So the predictor of ovarian tumor is the ovulation. It is more common in women who is more ovulating. The more you ovulate, the more risk of ovarian cancer. So the precursor for ovarian cancer is the gonadotrophins. In moms, there is a suppression of ovulation, so it is a protective factors. We have other epidemiological factor, other factor that enhance or reduce the incidence of ovarian cancer, as we see in the other. What about uses of fertility drug? It's one of enhancing the ovarian cancer. It's increased ovulation and increase the risk of ovarian cancer. Oral contraception and tubal ligation is a protective factor. It has been shown that patient with tubal ligation has 33% less risk of ovarian cancer. Also, patient did hysterectomy and unilateral oophorectomy. The remaining ovary, a risk of ovarian cancer in the remaining ovary is very low, and it is a protective factor. The most important predictor, most important risk factor of ovarian cancer is the genetic predisposition. There is a special families that are a carrier of BRCA1 and BRCA2, which is a gene located on the chromosome number 17. These are the carriers. They have 40% risk of developing ovarian cancers. They are also belong to a groups called the Lange 2. يعني her mother has a breast cancer, her father has a colonic cancer. A risk in these Lange 2 also increase. We discussed in the previous slide the epidemiological factor that enhance, factor that reduce risk of ovarian cancer. Now I'm going to discuss the figure classification, the staging of ovarian cancer. Stage 1 is limited to the ovaries. Stage 2 goes beyond the ovary to the pelvis. Stage 3 is going from the pelvis to the abdominal peritoneum, and the stage 4 is the distant metastasis. In stage 1 can be divided in stage 1A, B, and C. Stage 1A, if one ovary is involved. Stage 1B, if the two ovaries are involved. In both these A and B, there is no ascites, there is no tumors on external surface, and the capsule is intact. While in C, either it's one ovary involved or two ovaries with ascites or tumor on the surface, or there is a rupture of capsule. Now we shifted to the stage 2. Stage 2, as we mentioned before, is involve one or both ovaries with pelvic extension, also divided into A, B, and C. Stage 2A, when the extension is to the uterus or to the tube. Stage 2B, extension to the other pelvic organ, either bladder or to the bowel or to the parametrium. And stage 2C, A or B with ascites. Stage 3 involve one or both ovaries. As we mentioned, there is a peritoneal implant outside the pelvis, and or retroperitoneal or inguinal lymph node involvement, also divided into A, B, C. A, when there is a microscopical seeding of abdominal peritoneum. And on laparotomy, when we open, there is no obvious any plants on the peritoneum. Only when remove the omentum, there is a microscopical seeding of abdominal peritoneum. When we shift to the stage 3B, there is obvious lesion in the peritoneum. There is macroscopical disease outside the pelvis, but the size of the implant is less than 2 cm. Stage 3, when the implant is greater than 2 cm and or there is a positive retroperitoneal or inguinal lymph node. Stage 4 is the distant metastasis to the lung or to the liver. Now I am going to talk about screening for ovarian cancer. Why we screen for ovarian cancer? Is there any definitive screening test for ovarian cancer? The result is in the next slide. We screen for ovarian cancer because it is the 5th leading cause of death in a woman, and it is the most common cancer of female reproductive system. Also, we screen in order to detect the disease at earliest stage so that we offer the patient treatment and we improve the prognosis. Is there any definitive screening test? There is no definitive screening test. Can we apply the screening test for the whole population? This is also impractical. So we concentrated on the patient who is indicated for. And it's a selective screening, especially those with genetic predisposition. We have 3 methods for screening. This first is the routine pelvic examination. The second is vaginal ultrasound. And the third, the biomarker, which is CA125. We do pelvic examination if there is any suspicion or there's enlargement in the ovary and the patient is susceptible, so we shift it to the other steps of screening, which is the vaginal ultrasound. What are the suspicious lesions? What are the suspicious points in the ultrasound that raise possibilities of ovarian cancer? The first is increase in the size of the ovary. Note the ovarian tumor, increase in the size of the ovary. Sometimes the ovarian tumor is less than 1 cubic centimeter. If there is a lesion or there is a mass in the ovary, whether the mass is benign or malignant, it gives a certain criteria. If there is internal septation, it raises possibilities of malignancy. If the mass is partly cystic and partly solid, this is a malignant rather than a benign. If there is a bilateral ovarian mass, it raises possibilities of malignant. And we do Doppler ultrasound at the same time. If there is increase in the blood flow or there is increase in the vascularities also, it is a suspicious feature of a malignancy. The third method, if there is abnormalities in the vaginal ultrasound, we shifted to the third method, which is the CA125. The CA125 is a glycoprotein shedded by 85% of epithelial tumor. Only the mucinous give the negative value. The cutoff value is 65 international unit per liter. Any value more than 65, so we have to subject the patient for further evaluation. Why the CA125 of low specificity and sensitivity? First, we need a serial measure. Serial measure better improve the specificity and sensitivity of the test. This is number one. Number two, it has a false positive and false negative result. This glycoprotein usually covers the whole peritoneal surfaces, the liver, the pancreas, also the pelvis. So any lesion in these areas may give false positive result of increasing CA125. There are certain malignancy in which CA125 may be high, like liver and pancreatic. Also, there are a non-malignant condition in which the CA125 may increase, like endometriosis or PID, or even in pregnancy. So any irritation to the pelvic or to the abdominal peritoneum may cause increase in the level of CA125. So it is of a low specificity as a screening method. Now I am going to talk about the clinical feature. How would a patient with ovarian tumor may presented with? Usually it is asymptomatic. The symptoms may appear 12 months before the ovarian cancer is found. So the patient may have a cancer a year before the symptoms appear. The most important symptoms is the pressure symptoms. Either it's pressed anteriorly on the urinary system and give a urinary symptoms, or pressed posteriorly on the rectum and give us rectal symptoms. Also, it may press on the venous return, and the patient may present it with lymphedema, varicosities, and hemorrhoids. The second presentation is pain. The pain may be due to heaviness, due to muscle cramps, due to size of the ovary, or the pain may result from dysmenorrhea or dyspareunia due to pelvic mass, or the pain is related to the complication of the ovary, especially those with a long pedicles may undergo torsion, hemorrhage, or rupture. The other symptoms is menstrual irregularities, especially menstrual irregularities, those with hormone secreting. So those ovarian tumors, hormone secreting ovarian tumors may present with menstrual irregularity or other symptoms. It depends on the type of hormone release and the age of the presentation. So if the granulosa patient has a granulosa cell tumor, they are hormone secreting. They are estrogen secreting ovarian tumor. If granulosa cells occur in patient before puberty, the main presentation is the precocious puberty. The patient may present it with enlargement of the breast or the menstrual withdrawal before the age of puberty. If the granulosa cells occur in patient who already menopause, the patient may present it with postmenopausal bleeding. If it's occur in the reproductive age group, the patient may present it with endometrial hyperplasia. If the ovarian tumor is secreting androgen, the main presentation is masculinization. First, amenorrhea and sign of masculinization like clitoromegaly, hirsutism, and other symptoms of masculinization. The fifth and the last clinical feature, the patient may present it with malignant changes like ascites, vaginal bleeding, and malignant cachexia. We discussed the risk factors, we discussed the fecal classification, we discussed the presentation of the patient with ovarian cancer, and now we shifted the investigation. We do all type of investigation, especially the radiological and the CT scan or MRI, but there is no definitive investigative tool to confirm ovarian cancer. So the definitive diagnosis is at the time of laparotomy and by biopsy. There is a specific topic I want to discuss it here is a tumor markers. What is a tumor markers? Tumor markers can be used as a screening, as we mentioned before, and as a diagnostic test. It is a protein that's selectively secreted by the tumor cells. When it releases into the circulation, it can be detected into the peripheral blood. So, if the tumor markers, if the ovarian tumor is hormone secreting, like estrogen. So in early stages of the disease, we can detect the estrogen in the blood. When we remove the ovary, the estrogenic level will fall down and it recur again or raise again if there is a recurrence of the disease. We have three types of tumor markers. The first tumor markers اللي هو يسموه carcinoplacental antigen, which is HCG. The ovarian tumor that secretes HCG is the non-gestational choriocarcinoma, which is the germ cell tumor. The other types of tumor marker is carcinoembryonal antigen, which is the alpha-fetoprotein, beta-alpha-oncofetoprotein secreted by all the epithelial and some of the epithelial and some of the germ cell tumor. As I mentioned before, alpha-fetoprotein is secreted by germ cells, the yolk sac tumor. The last one is a tumor-associated antigen. So we have carcinoplacental, carcinoembryonal, and tumor-associated antigen. The glycoprotein CA125 is the tumor-associated antigen. Now I am going to talk about treatment. How would we treat the benign tumor? How would we treat the borderline malignancy? And how would we treat the malignant tumor? The benign tumor, benign ovarian tumor, if we are sure of it is benign at the time of laparotomy and it is cystic in nature, we do only cystectomy. If it is solid or partly cystic and partly solid, or the patient is more than 45 years of age, we do oophorectomy. We talked about how we treat the benign ovarian tumor. Now I'm going to talk about the treatments of malignant tumor. We have three steps for treating or three tools for treating the ovarian cancer. The first is surgery, which is the mainstay in the management. All stages of ovarian tumor should be subjected for surgery. The second is chemotherapy and the third is radiotherapy. What is the advantage of surgery? What is the rule of surgery? Surgery is diagnostic, as we say. The definitive diagnosis is at the time of laparotomy. The second benefit is staging. We can do staging. We assess whether there is a peritoneal implant or it is limited to the ovary or limited to the pelvis. We do staging. The third is therapeutic. We have two types of surgery, the optimal surgery and debulking. The optimal, we mean by optimal, we remove the whole tumor. The only residual deposit is less than 2 cm. If the residual deposit is more than 2 cm or there is difficulty in inoculating the ovarian tumor, we call this procedure is debulking. So our aim is to remove the whole tumor to leave not more than 2 cm residual deposit. The early stages of ovarian cancer we treated by total abdominal hysterectomy, bilateral salpingo-oophorectomy. We remove the omentum, we remove the lymph node, we remove the appendix. What do you mean by early stages? Early stages involve stage 1, A, B, C, and stage 2A. How would we operate on the patient? We open the abdomen by a midline incision so that we can extend it, the incision upward, to have a good view of the abdomen and the pelvis. This is number one. If there is any acidic fluid, we take acidic fluid and send it for cytology. If there is no acidic fluid, we install 100 cc of normal saline in the paracolic gutters, and then we aspirate it and send it for cytology. We check the liver, we check the diaphragm. If there is any lymph node, we have to take it for biopsy. The 5-year survival is good in early stages, between 67% and 89%. Early stages, stage 1, A and B, there is no need for adjuvant therapy. For those with advanced tumor, we do debulking followed by chemotherapy. Now I'm going to discuss a rule of chemotherapy. Chemotherapy play a central role, important role after surgery. We depend on the single drug regime to reduce the risk of complication, risk of side effects of cytotoxic drugs. The drug is the platinum-based drugs, either cisplatinum or carboplatinum. We give the patient 6 courses. Each course is 3 to 4 weeks interval, and each month we give the patient courses because they are still not without side effect, may cause neuro or nephrotoxicity. If there is no response to the single drug regime, we shift it to the combination of the drugs like hexamethylamine, 5-fluorouracil, and the other types of cytotoxic. Nowadays, there is a new drug called paclitaxel with a good response rate, more than 80%. We discuss the role of surgery, the role of chemotherapy, and now radiotherapy. Although it's play a little role in the treatment of ovarian cancer, still it can be used as an adjuvant after surgery. We do debulking, and instead of giving the patient a chemotherapy, we use a radiotherapy, or we used a consolidation, mukathaf. After surgery, we give a chemotherapy and then we subject the patient for radiotherapy. The third indication is a special type of germ cell tumor, which are radiosensitive. What are the types of radiotherapy? We have 2 types. Either we use an intraperitoneal radioactive isotopes at the time of surgery. We install in the paracolic gutter radioactive phosphorus or gold, or after surgery, after 1 week or 10 days, we subject the patient to external beam therapy. In patients with ovarian cancer, we have what we call a second look laparotomy. All the patients with ovarian cancer operated on have to re-operated on after 12 months, so that if there is indication for second look laparotomy is either in first surgery is there's too extensive adhesion and fixity, we do only bulking, so we want to remove the residual tumors, or we give the patient chemotherapy and we assess a response to the chemotherapy. So that's why we do a second look laparotomy. We have something called the immunotherapy in ovarian tumor. It has been found there is association between the immune system and the progression of the malignancy. So to improve, to enhance, to activate the immune system to get over the cancer, We give the patient immunotherapy. We have two types of immunotherapy, either specific or non-specific. The specific, we stimulate the immune system by Corynebacterium parvum or BCG, or we use a specific the tumor associated. We take the tumor cell, we irradiate the tumor cell, they're re-injected into under the skin of the patient, and we stimulate the immune response, or we use the cytokines and the interferon. We talked about how would we treat the benign, how would we treat the malignant by surgery, chemotherapy, radiotherapy, and immuno, and now we shift to the borderline tumor. Treatment of borderline tumor is by surgery. There is no need for adjuvant or consolidation treatment. We do a unilateral oophorectomy with the preservation of the other ovaries. Now we shift to the spread. The spread of ovarian tumor by three means, either spread locally, lymphatic, and hematogenous. In the lymphatic, it either spread with the para-aortic to the para-aortic and pelvic lymph node via the ovarian vessels, or it can spread with the broad ligament to the obturator and inguinal lymph nodes. Now I'm going to talk about each of these tumors, criteria, feature, whatever you call it, of each of these tumors. The most common type of a tumor is epithelial. The most common epithelial tumor is the serous cyst. The most common ovarian cancer is the serous cyst adenocarcinoma. It is usually bilateral, unilocular, only one locus, one cyst. Lining epithelium is cuboidal. The fluid is serous fluid. If this serous fluid contains a papillary projection or a calcified granules, it is indicate there is a sign of malignancy. The mucinous cyst adenoma or adenocarcinoma, usually multilocular and unilateral. It may attain the huge size. The content is mucin and the lining is columnar, tall columnar epithelium. Granulosa cell tumor also arise, as we say, from a granulosa cell. It produces estrogen. Representation is depend on the age of the patient, as I mentioned before. Arenablastoma arise from Sertoli Leydig, and they secrete the androgen. Presentation usually amenorrhea and sign of virulism. Mature teratoma, commonest tumor in the reproductive age group during pregnancy. 15% they are bilateral, contain sometimes hair, skins, or bone, can be detected radiologically, and asymptomatic in almost all cases. They are rarely malignant. Immature teratoma. Immature teratoma. Difference between mature and immature. Immature occur in children, young adult, mature in the reproductive age group. Immature teratoma, it is solid in nature. Mature teratoma is cystic. Immature teratoma are highly malignant. Mature teratoma, they are benign. This germinoma is a type of germ cell tumor, commonest type of germ cell tumor, occur in the second or third degree. As I mentioned before, they are radiosensitive and they secreted either estrogen or androgen or HCG, and the presentation depend on the type of hormone secreted by the tumor. The last two variants of germ cell ovarian tumor, the yolk sac and non-gestational chorious carcinoma, they are both are highly malignant. They are hormone secreting alpha fetoprotein secreted by a yolk sac tumor and HCG secreted by choriocarcinoma and occur in the young and the children. We have a syndrome known as Meigs syndrome. Meigs syndrome characterized by ovarian mass, which is fibroma, ascites, and pleural effusion. Once we remove the ovarian fibroma, ascites, and pleural effusion disappears. Thank you for your listening. If you have any comment, I'm, I'm ready to answer your question with the pleasure, and thank you again.